In today's video, we're talking about ArturaAI. Now, they have two types of models. They're looking at active surveillance and they're also looking at intermediate risk prostate cancer. And today we're going to focus on the intermediate risk prostate cancer. Now, a lot of these men in that category, they get radiation localized to the prostate, and then a lot of times they're given hormone therapy. But with ArturaAI, they're looking at whether a man will benefit from the hormone therapy or not. The reason they'd want to skip the hormone therapy is because it affects quality of life so greatly. The side effects are quite extensive. So today we're going to talk to Dr. Mark Schulz, who's a 30-year medical oncologist and who's focused solely in prostate cancer through his career. And he's going to talk about how do we contextualize this information and how would it apply to specific cases. So today, Dr. Schulz, we're talking about ArturaAI, which is a biomarkers test. And we've seen this, kind of come out in the latest advocacy journals. We've seen it come out in a lot of, popular publications that we've seen in prostate cancer. And so today we're going to be talking about it. It's an interesting test because it uses AI to analyze pathology data and to analyze a lot of the diagnostic data that prostate cancer patients get from their test results. And it's interesting because, it's about $700, but Medicare looks like they're covering it. There isn't an out-of-pocket cost for patients. They're still getting licensing here in California and in New York, but it looks like it's available in 48 other states. So first of all, before we get into the details of the studies and the New England Journal of Medicine Evidence Journal as well, can we talk about what is a biomarker test?
I don't actually use that terminology much, but the bottom line is that patients, and this is referring to patients with intermediate risk, newly diagnosed prostate cancer. These individuals are in an area of prostate cancer where, depending on how serious their intermediate risk disease is, they may or may not want to be more or less aggressive with treatment. Specifically, can they do radiation by itself, or do they need to add some hormone deprivation therapy, usually 4 to 6 months of hormone deprivation therapy to the radiation to forestall the development of metastasis in the future. That analysis is complex. That is looking at pathology, how high the PSA is, the characteristics of the tumor, maybe on digital rectal exam, compiling all that information and then offering an answer to patients. This is something I've been doing for decades, about whether or not they have something that's serious enough to warrant hormone therapy, or can they just get by with radiation and avoid all the side effects that hormone therapy is associated with.
Just to do some landscaping really quick for prostate cancer patients, they have a rising PSA, they go get a biopsy, they find out what Gleason score they have, and then they, get a PSMA and an MRI. We're talking about cases where they have localized disease in the prostate, and then they find out, okay, well, it's not Gleason 6, so we need to treat it. And so, since it is localized to the prostate, we're going to radiate the prostate and radiate the tumor. But a lot of times, as you said, we do have this hormone therapy question. Now, just going into hormone therapy really quick, it's chemical castration. The side effects are tremendous. Patients do, some patients tolerate it really well, some patients don't. But the side effects are anything from hot flashes, lack of testosterone, muscle, we lose our muscle mass through that process. And so there's a lot that patients go through, and they stay on it from anywhere from, it used to be 12 to 24 months, in between that time frame, 12 to 18, 18 to 24. And in localized disease, it was a shorter amount of time, but if you can forego hormone therapy, that sounds really exciting. So how can you be sure that this is absolutely safe? What is the data that's proving that a patient in this situation can forego hormone therapy?
We'll go into the sort of analysis that undergirds this decision-making process. But the idea is that, at least historically, if the cancer spread out to the lymph nodes and the bones, that was a preamble to dying of prostate cancer. Therefore, that needed to be avoided at all costs. And since well-performed studies have proven that the relapse rates are less when you add hormone therapy to beam radiation, the idea of not doing it is something that's considered to be unacceptable. If we're going to have people risking death, then we need to take every precaution against that. Thus, all these side effects that you mentioned related to hormone therapy are justified. That's, I think, a simplistic analysis, and I think there's a lot of that either-or thinking in the world just because of the repercussions or the thoughts, this is going to lead to someone dying, and we want to avoid that at all costs. It's really not that straightforward for a number of reasons. One is that we've gotten better and better treatment for metastatic disease. And a lot of these studies that showed improved survival by adding hormone therapy to beam radiation were done a number of years ago, before we had PSMA PET scans, before we had second-generation hormonal therapies. Advancement of technology has reduced the implications of relapse disease compared to what we were facing historically. The other relevant fact that needs to be brought into play when we make this sort of analysis is these are aging men, and if you're looking at a difference in metastatic rates 5, 10, 15 years in the future, we need to compromise our enthusiasm for treatment if someone's already 75 or 80 years old. The advancing age of the people that get prostate cancer reduces the repercussions of catching a relapse compared to someone that's maybe in their 50s. So there's a number of these factors that need to be ascertained. What's really nice about this new test is that it will give you a more concrete percentage for the type of cancer you have, and that percentage will say at 5 years, 10 years, 15 years, your risk of having a relapse if you do or don't do hormone therapy will be X, 5%, 15%. And then patients can look at that number and decide if they want to endure the side effects of hormone therapy right now to improve that number, or in some cases, they'll have favorable profiles that would argue that you don't even need the hormone treatment, and that's certainly helpful as well.
Before I get to my next question, this September, we're having an in-person prostate cancer patients and caregivers conference. And what I love about this conference is you get to ask your questions to world-renowned experts and get multiple opinions in one place in one weekend. You can learn more at pcri.org. Also, subscribe to our YouTube channel. This is a great way to support us. And if you would like to support us financially, you can do so at pcri.org/donate. Now back to my conversation with Dr. Schulz. I think something fascinating from the website and from the data that has been published regarding this is that 1/3 of patients would benefit from ADT. Why is it 1/3?
The industry has set a certain threshold of what they think is acceptable risk. In my view, those thresholds may not be relevant now that we have PSMA PET scans, we have second-generation hormone therapy. Let me just share some of the numbers. If you're judged by this artificial intelligence analysis that to have a favorable category, your risk of the cancer coming back if you do beam radiation alone is going to be somewhere between 3 and 8% over the next 10 to 15 years. And whoever designed the test this says that that's acceptable. And the patients who take the test and fall into an unfavorable category are going to have a risk of relapse if they don't do hormone therapy, somewhere between 5 and 15%. That, by the people that designed the test, was deemed unacceptable. I'm not sure that I agree with that. If someone's 70 or 75 years old and there's a 15%, let's pick the number 10% because it's easy to work with, a 10% chance that the cancer is going to come back if you don't do hormone therapy. And if you do hormone therapy, it's only a 5% risk. So you're improving the long-term outcome by 5%. That means 1 out of 20 people will cross over from not being cured to being cured if they take hormone therapy. So that's a lot of people getting unnecessary hormone therapy for that one person to benefit. I tend to believe now that we have PSMA PET scans that can pick up relapses much sooner. We have brachytherapy, which has better local control rates with IMRT. And then our salvage treatments are so much better now that we have PSMA PET scans. We can spot weld these metastatic sites. I tend to think that maybe a 15% risk of relapse at 10 years would be acceptable. So in summary, what I'm saying is that the test is really cool because it gives you a more concrete idea of what the risk of relapse is going to be. I'm not sure that I accept the parameters that are being offered with this test. They're saying if you're facing a 15% chance of a relapse, therefore you must take hormone therapy to reduce that to say 6 or 7%. Some patients, I think, may decide that the hormone therapy side effects justify that, but I think many others will decide, I think I can take a 5 or 10% risk because I want to avoid the side effects of hormone therapy right now, avoid that treatment, and I'll live with the increased risk of it coming back.
Well, let's take that example. So 75-year-old, they have a 10 to 15% risk of metastases. They've had localized treatment. What are the markers in which you would say hormone therapy is necessary?
Well, I think the marker is in the mentality of the patient. If you've got a patient who's not sexually active, who is very dedicated to fitness and is likely to tolerate the hormone therapy very well, who's savvy enough to use a reversible hormone medicine like Orgovyx perhaps rather than Lupron because the recovery is more predictable. All these things can mitigate the side effects of the hormone therapy so that individual can extract all the value of it without too much of the downside. But you take another individual who's, take an extreme example, someone who's newly married, and his experts are telling me you have to take hormone therapy. This is going to wipe out their libido. It's going to possibly have some lingering effects with erectile function afterwards. That individual is more likely to be willing to assume a little more risk. And these are not huge risks. If you have a high projected risk of relapse on this test, it doesn't mean that you're more likely than not to have a relapse. It just means that you're a little bit more likely to relapse than someone who has a slightly more favorable profile.
So let's say that the 75-year-old decides, we're going to skip the hormone therapy. They have the localized prostate cancer treated with the radiation. What does their PSA have to look like? What does their PSMA scan look like in order to go, okay, now we need to treat you with hormone therapy?
Patients who undergo definitive radiation therapy, their PSA levels should drop down to 0.2, 0.4, something in that range, and remain there indefinitely. Now that PSMA PET scans are available, if one of these individuals does develop relapse, say in the pelvic lymph nodes, which is the most common area, it's possible that they could be treated with radiation to the lymph node with no hormone therapy at that juncture as well. Modern radiation has become very tolerable and very effective, and the routine use of hormone therapy, even in the relapse patient, may not be called for.
You mentioned in younger men or somebody who's like newly married and they're in a different situation, but if you have a man who's maybe in his 50s and then there's that 10 to 15% increase that he could not have a relapse due to the hormone therapy, because of his age, would you encourage him to take it?
I encourage patients to understand repercussions of the treatment, understand the repercussions of facing a relapse, and balancing those things out, because it's, I believe, a personal decision for the informed patient to decide if these upfront side effects, which in some people are very florid and other patients are not that bad at all, depending on how people tolerate it. And something that's not talked about, patients can start off on hormone treatment and see how they do, and if all of a sudden they're running into side effects that seem way overblown from what they've faced or expected, they can stop it early. They're not locked into the treatment, especially if they're using one of these new oral agents like Orgovyx. So the decision-making process is very much on the patient, as long as the patient has been educated as to the relevance of all this information.
As far as the test goes, how can we, contextualize this test if somebody's making a decision on whether or not they should take hormone therapy, and how will this test help them?
Specifically, I tried to summarize it as a way for patients to get a handle on actually how much risk there is of relapse. A lot of these reporting formats, because the doctors that are treating prostate cancer are so busy and they're doing a dozen different things, and taking time to explain this to patients is a difficult proposition. So they love it when a test comes back and says, oh, this shows you should treat it, or this shows you shouldn't treat it. Thanks, let's move on and we can get to the next patient. But I just don't think it's that simple. The repercussions of the hormone therapy are going to vary from patient to patient, and they're going to be perceived differently from patient to patient. Some patients would perceive these side effects as not that big a deal. Other patients see it as a very big deal. I think the test is very helpful for people understanding what their real risks are, and then with that information, they can make an informed decision.
So as far as the background of ArturaAI, there was some large, phase 3 randomized studies that were done in about 5,000 patients. Can you talk about that data and what the findings were?
Clinical trials where patients with intermediate risk prostate cancer were all treated with beam radiation, IMRT, certain individuals were selected to have 4 to 6 months of hormone deprivation along with the radiation, a maneuver that these studies and others have proven to show lower relapse rates, better 5, 10, and 15-year survival rates. The problem is, where is the dividing line and what this artificial intelligence data provides is for some patient who's diagnosed with a 4+3 and a PSA of 7 and has a specific profile, do they have a serious enough cancer to warrant adding hormone therapy to the beam radiation, or do they have a relatively favorable cancer for which there'll be little change in the cure rates by adding the hormone therapy? And in that individual, the hormone therapy is only adding side effects. It's not adding value.
These specific studies and what they're talking about is about beam radiation, IMRT, as you said. But what about in situations where you have brachytherapy, where you're using seeds directly into the tumor in the prostate and, encircling it and making sure that they're capturing it? The brachy studies have shown that it is quite effective, even in comparison to IMRT and in comparison to surgery. So can you speak, maybe we'll see this in brachy in the future, but for right now, how does a patient contextualize really which one to get?
Well, this doesn't address whether you should do IMRT or brachytherapy, but as you pointed out, there are randomized trials showing higher cure rates with brachytherapy compared to IMRT. Using brachytherapy in patients who are not taking hormone therapy is one way to offset those risks that may be suggested by a test like this, where there's an indication that the cure rates won't be as favorable in this particular profile patient. Well, that may not be true if someone has more confidence that the local treatment will truly eradicate the disease in the prostate, which is what brachytherapy accomplishes. Brachytherapy delivers a higher dose of radiation than IMRT can, and it results in better cure rates. So one of the advantages of hormone therapy with IMRT is that it helps kill off some of the cancer inside the prostate. There's also thoughts that it may help take care of micrometastatic disease as well. But with these intermediate risk patients, the incidence of micrometastatic disease is pretty low. So a significant amount of the value of adding the hormone therapy to the IMRT has to do with ensuring that you get it all in the prostate. Whereas with state-of-the-art brachytherapy, the confidence that you're going to get it all in the prostate, I think, is greater. And maybe there's less arguments for adding hormone treatment to well-performed brachytherapy than there is for adding hormone treatment to well-performed IMRT.
They've had some people that were randomized with IMRT in the study, and they had some people that were randomized with IMRT plus hormone therapy. So what was the end result? And were they looking for overall survival? What was the end point?
So the ultimate endpoint was how many men developed metastasis at 15 years post-treatment. When you look at the two groups, where the unfavorable group and the favorable group, the incidence of metastasis in the favorable group at 15 years was about 5% of men. In the men who were in the unfavorable group, the one that they're arguing should get hormone treatment, the incidence of relapse at 15 years was about 15%.
When it comes to artificial intelligence, I think there's a lot of media, there's a lot of things behind it, and we all kind of have this mindset like, we have the robots are going to take over the world, but now we have these new things where it can help us identify large data sets and really who's going to benefit from certain treatments and who isn't. I think my question is, for any man that's in this situation where they are looking to get their localized prostate cancer treated, would you have every man take this test?
Maybe I wouldn't, but I spend my whole life doing this sort of analysis all day long, and that's not true of most physicians treating prostate cancer. How can information hurt us? I'd say the only way it can hurt people is if it's misinterpreted. So I would never take a no treat statement from a report as the last word. I would use the information to help decide if there's enough upside in the treatment to justify the side effects that are going to come along with the treatment. I love getting the information. It may only validate what we already know, or it may offer some new insights. I'm very excited that we have access to information like this. And the analysis that they're doing it's a very complex analysis. If you're not doing it regularly on an ongoing basis, I think it's over the top difficult for most physicians. I think it's an elegant test that can give deeper insight into each individual's status, but I would never take a go, no-go report as the final word as as to your selection of treatment. It's something that needs to put in the context of the individual needs of that patient, the age of the patient. Are they using IMRT or not? Have they had a PSMA PET scan already or not? All these things are going to further modify the projections about what's going to happen in the future.
As a caregiver myself and somebody who's worked with tons of prostate cancer patients, if this was my dad and I was sitting in a chair with you and in the office and I was talking to you about it, my number one concern would be, if my dad is going to forego hormone therapy, is there any danger? And is there a benefit to him taking it later? Is it neutral? Will the hormone therapy still be as effective if he takes it later versus now?
Well, the general rule of thumb in the cancer world is that any treatment that you do or propose to do will be somewhat more effective if it's done now rather than later. Because if it's done later, you've given the cancer a head start, allowed it to put down some deeper roots, and the idea that it's going to be equally effective at a later date would be called into question. All that being said, prostate cancer, even when it's relapsed, is much, much more manageable these days than it used to be. What we can see from intermediate risk is that the vast majority of men that are in this category don't need hormone treatment. Worst case scenario, 85% are going to be cured with no hormone therapy. So we're only trying to improve that 15% to reduce that maybe to a 5% relapse rate rather than a 15% relapse rate. But a lot of men are going to have hormone treatment. Remember, the test only eliminates a third of men in the intermediate risk. So they're still saying treat 2/3 of the people to get this reduction of 15% to 5% in the projected relapse rate for the men that need treatment. This sort of analysis, I think, is, as I said before, is very helpful and useful in understanding the context. But I'm not convinced that everyone with a 15% risk of relapse should be on hormone treatment.
So I want to get into some specifics that we talked about today. First of all, as we said, this is a biomarkers test, so they're taking your pathology report and some diagnostic reports, they're putting it into the AI model, and they're looking at the reported outcomes. I would take that report and talk to your doctor about it and make sure that you are looking at the bigger picture of your particular prostate cancer case. And is this helpful? Is this not? And it just gives you more information. I think a lot of times when we take these tests, we kind of can see things very black and white, but you want to look at your age, you want to look at what your PSA is doing, how large is your prostate, where is your cancer at, what do your PSMA, scans say, and where is the prostate cancer, and what's the Gleason score, and what are the other biomarker tests telling you about it. I think these are all helpful pieces of information because what we're coming into is an era of strategic medicine, personalized care, and we want to make sure you have a shared decision-making process with your doctor. So I would look at the website, ArturaAI. They have sample reports on the website. It gives a lot of information. I know I said that the test is not currently licensed here in California and New York, but I would look at the date of this video when you're watching it. I suspect they will get licensing soon, so check back to the website at ArturaAI to see if that has changed. But they have a lot of information, whether it's covered by Medicare, which it looks like it is, with a zero out-of-pocket cost, and also you can contact them if you don't have Medicare and you have to pay for it out of pocket. I think all of this is really great and it's exciting because it's a new era where AI is being used to analyze large data sets and tell us whether or not things will be beneficial. Now, if you are in the case where maybe you took this test and it comes back that you would benefit from hormone therapy and you have decided that you're going to undergo hormone therapy, I would watch our other videos on how to mitigate the side effects of hormone therapy and try to lessen them, whether that's working out, diet, exercise, things like that. Also estrogen patches for hot flashes. There's a lot that can be done, but it's really cool that we are starting to see predictive tests letting us know whether or not this would be beneficial to you, a treatment like that would be beneficial to you. It really follows the line, first, do no harm. We're trying to do the least amount of damage to the overall quality of life while still doing damage to the cancer itself and effectively trying to get those cure rates. And so this is really great. I'm excited about this technology and there will be more to come. Now, ArturaAI has also produced an active surveillance model and we will be talking about that, as I said, in future videos. So please click that subscribe button so you can stay up to date. We appreciate you watching. Please remember, most of all, you're not alone, and I hope